Good morning, everyone. I'm Louise Ivers. Welcome to Mass General Brigham Global Health Grand Rounds. We have a very exciting full house today for our conversation discussion. So welcome to all of our speakers and panelists. I'm going to introduce Dr. David Duong and allow him then to introduce the rest of the group. Dr. David Duong is the director of the Harvard Medical School program in Global Primary Care and Social Change. And he's the Associate Director for the Partnership for Health Advancement in Vietnam, which is a Harvard Medical School global program. He's the Global Principal Investigator of the Strengthening Integrated Care and Treatment of Hepatitis into Primary Healthcare Project, which we're going to be hearing about today. David has been focused on strengthening primary care systems through systems design and workforce development in a variety of global and domestic contexts in Vietnam, Philippines, Laos, Cambodia, Korea, and in 3 rural states across the United States. He also serves on the World Health Organization's Technical Advisory Group on Integrated Care Systems, with a focus on primary care. David completed medical school at Harvard, was in the HemiDoc program at the Brigham and Women's Hospital for Internal Medicine, and is now a primary care physician at the FIDSA Center at Brigham and Women's. Welcome, David, and your colleagues, and I will pass over to you to take us through your presentation and discussion. Thank you.
Great. Thank you so much for that warm introduction, Dr. Ivers, and thank you and hello, good morning to the Harvard's global health community across our campus, and thank you so much to the Mass General and the Brigham and Women's Hospital for hosting this us here today. I'm here joined by a really diverse team of folks from Asia Pacific and Vietnam and the Philippines, as well as colleagues from industry and collaborators from across Harvard. And I'll have them be introduced during our session today, which will include a short presentation from me on our project on hepatitis strengthening and integration into primary care in Vietnam and the Philippines. Afterwards, I will hand it over to my colleague, Dr. Bethany Holt, to introduce our panelists. And a brief introduction on Dr. Bethany Holt. She is the Associate Director of Health Systems within Harvard Medical School's program in Global Primary Care and Social Change, and she also directs our hepatitis project in Vietnam and the Philippines. Beth holds a Bachelor's of Art and Bachelor's of Medicine and Surgery from the University of Queensland in Australia, an MPH in Global Health from the Harvard Chan School, where she attended on a Fulbright scholarship, and then she completed a postdoctoral fellowship in health systems and primary care at the Brigham and Women's Hospital's Division of Global Health Equity. After Beth takes over the presentation from me, then she will introduce our panelists who you see here today. So without further ado, I will share my screen and start the presentation. So we will be talking today about a multi-sectoral partnership that works to integrate hepatitis care and treatment in Vietnam and the Philippines within primary care through putting people at the center. Here are the relevant disclosures and also the text for CME credit. So the learning objectives today is to understand and appreciate the significant global burden of viral hepatitis, to understand what people-centered care is and how it's been applied and how we've applied it to designing a new primary care model for hepatitis screening, diagnosis, and management in Vietnam and the Philippines, discuss the resources required to operationalize people-centered care approaches and its benefits for local ownership and bottom-up policy change, and then to critically reflect on the importance of intersectoral roles of public, private, academic, and community stakeholders through our robust panel that we will have after my talk. So just quickly on the status of viral hepatitis, you can see the global burden and the mortality of viral hepatitis on the screen here. The statistic that really speaks to me and I think I found really profound is that by 2040, viral hepatitis is expected to account for more deaths than those due to HIV, TB, and malaria combined. And it's also associated with significant psychosocial consequences for patients and their families, including fear, distress, stigma, discrimination, social withdrawal, and have led to societal exclusion. We can see in Vietnam and the Philippines that that both hepatitis B and hepatitis C are extremely prevalent in the communities and in the countries, and yet, however, those who are infected with the disease, around 1 or less than 1% of those diagnosed with HBV or HCV have been treated or appropriately treated. The WHO has really worked with country governments and other UN agencies to have a goal of hepatitis elimination by 2030. And country governments have signed up to that goal and have committed to that goal. And the WHO has recommended that in order to eliminate hepatitis, we really need to be looking at an integrated people-centered care model, in which countries are encouraged to base decision-making on their national and subnational context, population health needs, and health system strengths and weaknesses through decentralizing and integrating hepatitis services into primary health care. Now, these are really big words, and what does that mean? And these are very lofty ambitions. And our project is an attempt to operationalize what integrated people-centered care in hepatitis programming and elimination means within primary care. So our project is called Strengthening the Integrated Treatment and Care for Hepatitis, otherwise known as STITCH. And we have 6 phases to our project, and it started in May of 2022 and goes through 2026. And we've completed 3 phases so far, including the preparation, research, and co-design phase. And we're currently testing our model of care right now before we scale it up to additional provinces in Vietnam and the Philippines. I want to emphasize here that we've involved people with lived experience of hepatitis throughout the entire phases, both in the preparation and the research phase, as well as the co-design phase. And I'll share with you all a little bit about what that means. And the goal here is to design a new model of care for hepatitis care and treatment at primary care facilities. And hepatitis is a unique disease to allow us to do that, because hepatitis C is very much so curable, and it allows for us to pilot out a model of care in which a disease can be cured after a duration of time. Whereas hepatitis C, as most of you know, is a chronic disease. So it allows us to pilot a model of care in which patients engage with primary care over the course of their life. We started at one province in both Vietnam and another province in the Philippines to implement a model of care, which is currently happening right now. And we're hoping through quality improvement and evaluation to continuously improve that model of care so that next year we can start scaling it. So with this multi-sectoral partnership comes many different phases to implement the project, only some of which are shown here. We have partnered with government, both at the national and subnational levels, to get their buy-in early on in the process so that they can kind of take the learnings of these, of our findings and then scale it. We've also worked very closely with healthcare providers, including the Hepatology Society of the Philippines, the Vietnam National Tropical Diseases, and provincial and district care facilities, because they are the ones who are delivering care along with healthcare providers at primary care clinics. We work with academia within the country as well. One of our biggest partners is the University of Philippines in Manila. And then with private sector and specifically Gilead Global Patient Solutions, who both funds this work but also contributes technical expertise. And finally, we have robust representation from patients and communities, one of whom you'll hear from later on during the panel. And she represents, Ms. Joshua represents the Philippines Yellow Warrior Society, and in Vietnam, we work with the Vietnam Labor Union. So the first step that we did was that we, in our preparation phase, was to understand the political landscape and the regulatory landscape around hepatitis care and treatment in both Vietnam and the Philippines, and specifically at the primary care level. And how we did that was we took the WHO operational framework for primary health care and looked at their strategic levers, including political commitment and leadership, governance and policy frameworks, funding and allocation of resources, and engagement of community and other stakeholders. And through literature review, policy review, and key informant interviews with folks in government at both the national and subnational level, was able to rank how Vietnam and the Philippines did in comparison to the strategic levers to integrate hepatitis into primary health care. And from this, we found that Vietnam was ranked a little bit marginally higher than, better than the Philippines as it comes to the policies and regulatory frameworks around primary health care and specifically hepatitis service delivery at primary health care facilities. After that, we embarked on a patient journey mapping. And the research methods that we utilized was doing 63 semi-structured interviews in which we interviewed and followed 63 people living with hepatitis B or C in Vietnam and the Philippines to understand their enablers and their barriers, and also to understand the different journeys that patients take in order to access hepatitis care services in both countries. We use purposeful quota-based samplings from facility registers. And then from there, we use a rapid deductive thematic analysis to quickly analyze the data and then use that data in the next phase of the project, which is the co-design phase. And this rapid deductive thematic analysis was adapted from a hypertension framework that also utilized the same process in low and middle income countries. Simultaneously, we did a health system assessment of providers and facilities and using the WHO service availability and readiness assessment tool of the same facilities where we took the patients from to understand how hepatitis services were being delivered and if they were being delivered and what services were available. And then we did focus group discussions with healthcare workers from the same facilities as well. So all that information led us to see what a model of care was currently happening, and we were able to divide that into 3 phases of care, which is the pre-awareness and testing phase, the linkage and treatment initiation phase, and then the ongoing treatment and recovery. So here we separated out into enablers and barriers that patients experience. From the enabler side, in the first phase, it was patients who had familiarity with the health system, either because they had an existing chronic illness or they've had a family member who helped them navigate through the health system because the family member or the patients themselves were a healthcare provider. So that enabled them to access testing services. And then in the linkage and treatment initiation phase, we found that strong family support to meet financial, logistical, and emotional needs were really a top priority in order for patients to get linked and treated. And then in the ongoing treatment and recovery phase was high motivation to protect family. So the patient's high motivation to protect family, as well as the patient's desire to return to work to make an income, was a strong enabler. So as you can see here in the enablers, family and support was a key theme that we found. In terms of the barriers, in the pre-awareness and testing phase, we found that it was low awareness and significant stigma that prevented people from testing. And in the Philippines, the issue of stigma was much more relevant than in Vietnam, although it did exist in Vietnam. In the linkage and treatment initiation phase, we found that complex navigation, inadequate counseling by healthcare providers, and the inconvenience of treatment really led people not to be treated and linked to care. And this inconvenience here meant that people had to travel extremely long distances from their hometowns or villages to provincial or even capital cities for treatment, losing a day of work, often multiple days of work, and then a family member having to accompany them. And then on the ongoing treatment and recovery phase, it was misconceptions about medication or chronic disease care, thinking that once they felt better, they could they didn't have to take the medications anymore, or that the affordability of medications was in a barrier to ongoing treatment and recovery. So we took all that information, and what we did was then we initiated a co-design phase where we brought in all of the stakeholders that I previously talked about, from national and subnational governments, from healthcare workers, and from patients and families. And we thought and we worked to share and disseminate the findings from the patient journey mapping, walked participants through an exercise where we empathized and tried to put ourselves in the patient's shoes to understand and to feel what the frustrations that they were feeling with in accessing hepatitis care in the current state, and then working together to define what the problem was, and define problems at a high policy level to defining problems that were what were considered low-hanging fruit. And then from there, ideating solutions to those problems, prototyping those solutions, and then we're currently in the testing phase of testing the entire model of care. So from the model, from the co-design phase, and this is a complicated slide that shows the model of care for Vietnam and the Philippines that was developed with patients, policymakers, and healthcare providers, we could see 4 themes that came out of it. One, which was optimizing clinical pathways and linkages to emphasize primary care. So this is really patients saying that they really wanted convenient care where they work, where they live, and integrating hepatitis care and treatment services into primary care. The second was to build health worker capacity and capability to manage hepatitis in primary care. A lot of patients shared with us that they really needed more robust counseling from healthcare workers, so building up healthcare worker confidence and capacity to counsel patients once they received a diagnosis, and then putting in new programs such as telementoring and telecoaching of specialists to help primary care providers increase their capability in managing hepatitis within primary care. The third theme that came out, and the third area of intervention, is improving facility and systems readiness at the primary care level. So that was ensuring that drugs were stocked, ensuring that that reagents were also stocked, and that their existing labs could do the initial testing for hepatitis. It also meant things such as specimen transfer systems were put in place. So for example, in Vietnam, social health insurance would reimburse specimen transfer taken from primary care and community-based clinics to go to central laboratories, but that system was not in place yet. So spending about 3 months to put that system in place so that patients didn't have to go and travel themselves to the provinces or to the national level to get tested for hepatitis, but that they could get tested at the primary care facility, and then that lab sample could then be brought to the regional lab, and then the results brought back. So even though from a policy and regulatory perspective, it was feasible, the actual implementation of that was not, and we had to really test out different models to see how we could implement that. And then lastly, the fourth area of intervention was activating people in the community to engage with primary care, reassuring them that the services at the primary care were trustworthy, that they were good services, but also sharing with people that what hepatitis is and raising their awareness on hepatitis. So what we are currently doing right now, and that started in January of 2024, is implementing this entire model of care that you can see in the blue here, which is the initial screening at primary care, post-test counseling and linkage to patient navigation and support, followed by confirmatory testing, management and consultation, and treatment initiation, doing a 6-month follow-up and then a 12-month follow-up. So we're currently putting in place this entire model right now. And in the green below it is the research study that is currently ongoing as this model of care is running. So that includes many surveys of patients at within 14 days of confirmatory testing to understand their experience with parts 0, 1, and 2, and then doing another patient experience and health literacy survey at the 6-month mark to understand the person-centeredness of care. If the patients experience any stigma, how they would rank their experience with healthcare providers, etc. And then we'll also be doing a healthcare provider experience survey, a healthcare worker competency assessment at the end of the intervention as well, and then repeating the health facility readiness assessment as well. So we've developed dashboards right now as we're running this model of care. And this dashboard, this is an example from the Philippines. This dashboard gets updated every single week on the number of patients screened, who were reactive, who were linked to care, eligible in treatment, so that our teams in Vietnam and the Philippines, as well as our government partners at the subnational level and at the clinic level, can immediately react to this, to the findings of this dashboard. And you can also see on the Philippines specific dashboard that we also have, how much anti-HCV is in stock, how much HCV RNA is also in stock in terms of laboratory and drugs, so that so that we can prevent stockouts and keep the services running. So now I'll hand it over to my colleague Beth to talk through our understanding of people-centered care and how we've integrated that into the project.
Hello, everyone. It's great to be here and speak to you all. I will briefly speak about people-centered care before handing over and introducing our wonderful panel. We wanted to take a moment to define people-centered care as we understand it, because it's something that sounds very lofty and has many definitions. The way that I find it easiest to understand is to chart over time how our understanding about the relationship between physicians and patients has changed. So I don't think it's at all controversial to note that over time our profession has been known to be paternalistic, hopefully not as paternalistic as is stated by Benjamin Franklin back in the 1700s, but still in many contexts around the world, high and low income, we see examples of unequal power dynamics, which mean that what the doctor says goes. In terms of moving from a paternalism and introducing the idea of patient-centered care, we have our psychiatry colleagues to thank, who were the ones to first challenge the purely biomedical model and bring in the psychosocial elements of managing and caring for patients. I think patient and person-centeredness are often used interchangeably, but after a literature review, the kind of core distinct elements of person-centered care that we've distilled include this elevation of autonomy, such that patients really are engaged as shared decision makers in their care. There are relational dynamics that are important. So the experience of care, that it's respectful, that it's empowering, and that it involves patients' families where they would like it, is important. We emphasize prevention and wellness, which means going from seeing what's wrong with the patient to seeing what we can do to keep people healthy. And it enables holistic care of the entire person. So that means considering their social and cultural context, which requires a team-based and multi-sectoral approach. In essence, I think of person-centered care as going from people-centered, patient-centered care as restoring functional life, person-centered care is promoting a meaningful life. To jump from there to people-centered, we take the concept of shared decision-making and apply it at a macro level. So this means involving patients, families, and communities, not only in creating their own care goals, but in being involved in the research, design, and delivery of healthcare services themselves. So co-producing and shaping these services that we all work in and use. If we could go to the next slide, David. So I won't elaborate very much here, except to say that, apologies for that sound. David, do you mind just covering this slide, and then I'll keep going?
Yeah, so in here, we how we've integrated people-centered care within our project is that we, in the research phase, We have elevated people's experience in care in additional to the clinical outcomes to ensure that we measure what matters to people. We've involved them in the design of both the research questions as well as looking at the research, the patient outcomes and the outcomes from their hepatitis experience to feed back into the model of care. In terms of implementation, it involves local stakeholders in a participatory process that generates ownership and really improves the quality of the technical deliverables. So again, really incorporating the patient experience and the person experience and elevating them and bringing them to the table so that they can feed into the model of care. And finally, in terms of governance, the creation of community advisory boards and involving community organizations to both the governance of this project as well as the dissemination of the data that's coming out of this project, and then the quality improvement reviews, sharing those dashboard data with patients and communities so that they can then give feedback into the strategies to address the issues that are coming out of the information that we're getting. Okay. Back to you.
Thanks. Thank you. I think what better way to illustrate the concept of people-centered care than to hear from some of the voices of the people who are involved in our project, just as a few who are here with us today. I'll briefly introduce them in the order that they will comment and then hand over to them. So first, we're very happy to welcome Ms. Joshua Pacayra, who is the National Project Officer and Treasurer for the Yellow Warriors Society of the Philippines, which is the country's national patient advocacy organization for people living with hepatitis B. She's been an active advisor and involved in our Stitch project since its inception in 2022, and first shared her story of living with hepatitis at the World Health Assembly last year. So we'll hear from Joshi in just a moment. We also have Mr. Manu Gaspar, who is the project manager of the Stitch project in the Philippines. He is from the National Institutes of Health at the University of the Philippines and is experienced with improving healthcare access and systems through digital approaches and implementation science, with a Master's of Data Science from the Asian Institute of Management. We then have Dr. Thuy Pham, an infectious disease physician with many decades of experience in tropical medicines and re-emerging infections, HIV and hepatitis. She is currently our senior clinical advisor to the Stitch project in Vietnam, and previously was the vice director of the Department of Infectious Diseases at Bach Mai Hospital, one of the top medical centers in Vietnam. We have Todd Pollack, Dr. Todd Pollack, who is the medical director for the Partnership for Health Advancement in Vietnam, or HIVN. His work also focuses on strengthening health systems in low middle income countries. He is a research faculty at the Division of General Medicine and an attending physician at the Infectious Diseases Department of BIDMC. He was based in Hanoi for more than a decade, working with Thuy and many of our other colleagues in HIVN as its country director. And finally, we have Ms. Sinit Mehtsun, who is the head of health systems engagement at Gilead Sciences. She has 15 years of experience across health system design, policy and project management in low middle income countries, and has worked with many ministries of health, payers and public and private networks across the US and globally to advance that goal. She is also has a Bachelor of Science from Biochem, but is a T.H. Chan Masters of Public Health alumni too. So it's good to welcome her back to Boston virtually. So to begin our panel discussion, I'd like to invite to ask Joshi Pacayra. Joshi, thank you for being here with us again today. Can you kick us off by sharing with us more about what it felt like for you to be part of the Stitch project and what it was like having a seat at that table and what challenges you had to overcome?
Okay, thank you, Beth. Hello, everyone. Before I answer the question, I'll share a little bit of my story. Again, I'm Joshua Pacayra, a hepatitis B positive since 2005. I was trying to be a nurse but discovered that I am positive with hepatitis B upon my internship. It was a total shock, but the most depressing was the discrimination from my very own family, friends, and community. I felt down, depressed when the doctor said that I only had 20 years to live. It took me many years to decide to come out and search about hepatitis B. And if there's are other people experiencing what I was experiencing. Upon searching, I found the only hepatitis B organization in the Philippines, which is the Yellow Warrior Society. I actively participated in the organization activity. I learned a lot. I learned more about hepatitis and found that what the doctor said about 20 years of living was not true. I began more engaged with the organization and joined different collaborative activities. But even at that moment, I never had time to connect with doctors and lawmakers because it was very challenging and it takes a lot of courage to come out. The truth is in November 2022, it was the launch of a state project here in the Philippines where I was invited as a participant. I really did not contribute much. It's like I was there because I was invited and they need patience. Then there was another invitation for the first co-design workshop in early 2023 with the medical expert from the State University and from Harvard and to our partner hospital, the Tarlac Provincial Hospital. I introduced myself, initially I introduced myself as an advocate because I felt ashamed for having hepatitis B and I couldn't trust anybody. I was afraid that those people might also discriminate me. I did not speak unless asked. I did not ask any questions and my answer was always from the general knowledge as a member of an organization. But that changed day by day from one workshop to another workshop. I felt more and more encouraged as it felt like we are building a family, not just a project. The stage co-design workshop validated my feeling and eventually allowed me to become honest to myself and to others. That I, a hepatitis B patient, have a role for the social value and care planning. That it's possible to make a care plan that caters to the expectations and needs of the patients like me. I become relaxed, comfortable, and I was able to connect with them. And by opening myself and getting positive feedback, it made me feel the sense of confidence and power. Everyone made me feel heard, that my experience living with hepatitis is something that can inspire others. The feeling that I can lead and stand in front. It challenges and wakes the voice inside of me that I didn't know that I had. And I know there's still a lot of work, a lot of improvement I need to do. But I know and I'm confident that my Stitch family is always on my back. Thank you, everyone.
Thank you so much, dear Joshi, for sharing again. It always makes me so proud to have you part of this work and to share your story with us. With that, I think I'd love to turn it over to Manu. As we heard from Joshi, it's not easy bringing together these different types of stakeholders, which was necessary for co-design. So tell us a bit about the challenges you faced in implementing this and how they were overcome.
Thanks, Beth, for that question. And hi, everyone. everyone. So for the Philippines, we faced many different challenges, some of which Joshi has shared earlier. But I guess the biggest one was the resistance, not even to the actual change, which was yet to happen then, but with the resistance of the idea of change. And in the Philippines, our healthcare system, I would describe as very much physician-centric. And a lot of power definitely resides with the physician, because they often decide, and people living with hepatitis just listen. And so the idea of change, this people-centered model of care, made a lot of them worry. They thought it required new resources and a new set of responsibilities. And when we further unpack that, what we've seen is that, a lot of power actually is held upon by the policymakers that we work with, who, dictate and decide what and where resources go to. And so when we held initial meetings with them, it was always the usual suspects in that decision-making table, myself included. They understood why I and my university was present, why the regional health managers were present, but they were surprised why primary healthcare workers and people with lived experience were not at the same table. And while this is often a thing that, can discourage the work, we viewed it as a opportunity for us to rebuild and reshape the power relationships that exist as we make this change happen. And so to what Joshi shared earlier, we held these co-design workshops as a platform for all of the stakeholders to connect, to learn, but also to challenge each other. So there definitely was a lot of tension present. People with lived experience shared, their experiences, their issues with physicians and vice versa. And this was a turning point for the Philippine team, especially with the policymakers. They're too far from where the actual care and treatment is happening. So this was something new to them. And one thing that we did while facilitating was just to let everyone live in that tension. It was definitely uncomfortable at first, but these were very important conversations to be had. It allowed us to underscore a key aspect of our co-design approach, which is empathy. And so in these workshops, we empathized with each other, allowing us to see where people come from and genuinely listen to the challenges they experience. And, eventually over months, over weeks, gradually, people warmed up to each other, creating those safe, trusting relationships. We tried to be creative too, because as you know, trust, safety, education does not only happen at formal meetings. In our case, it also happened informally over chats and emails and other events, letting them know about the global examples that we have when it comes to participatory engagement in healthcare. But I guess most especially at karaoke nights, where people like Joshi and Beth and David and Thuy and Sinit, everyone here are singing with our primary healthcare workers and policymakers. And all of these obviously did not happen overnight. We needed the time to learn and relearn how to share that power. And so we needed to pace the change gently. So we collectively and, embrace, own, and be accountable for the change that we're making for the model of care that we're implementing, I guess as a family, as to what Joshi shared earlier. And now that we're in our first few months of implementation, I'm happy to share that, our approach is allowing us to provide care and treatment to people living with hepatitis. It's definitely more, slower. It's more resource intensive, but that is all intentional. It's what really creates that strong foundation for implementation, that high degree of empathy, of collaboration, and shared ownership.
Brilliant. Thank you, Manu, so much for those really insightful illustrations of how co-design is brought to life. And we've talked a lot about primary care providers so far, and their important role in the co-design and the model of care. I'd like to now turn to Dr. Thuy. Thuy, as a specialist infectious disease physician, can you help us unpack why it's so important that this project focused on primary care and primary care providers as the place to manage hepatitis?
Thank you, Beth, for your great question. And hello, everyone. So as Beth already introduced, I am an infectious disease doctor. During my previous work at a tertiary care hospital, I saw many patients with chronic hepatitis B and C, and many of them had liver cirrhosis or liver cancer. So when we talk with the patients, we learned that some of them did not know that they have the disease. Others may have something wrong with their health, but it took quite some time until they went for us. Long way to the tertiary care facilities, and money were among the concerns, as they were not able to have hepatitis care close to where they live. And it was sad that we could do very little or nothing at that time for these patients to save their health or even lives. As we all understand, people-centered care means that the service is convenient and affordable for people. Patients and their families are informed about their illnesses, and they are part of the care decision making. For people with chronic hepatitis, people-centered care means that they can access to screening, diagnosis early, get appropriate treatment, and stay healthy. That care should be provided at primary health facilities that are close to community, with the healthcare workers capable of giving a high-quality, evidence-based service. So that opportunity came to us as we are doing this project. So during project, we have an unique opportunity to support the primary healthcare workers in building the capacity across the whole cascade of hepatitis care, from screening to linkage to care and to appropriate management. So we collaborate with the experts from national and provincial levels, providing training as well as the technical assistance to the primary health providers. And we focus on both clinical and operational skills. And besides that, the training also covered the people-centeredness, such as how to provide counseling to encourage people get tested, how to empower people living with hepatitis in making decisions for their own health, own care, and so that they will stay on care to achieve a good treatment outcome. So during this training and technical visits, it's amazing to see that primary care providers were very engaged and they were very eager to learn. So our project has been rolled out for several months by now for the screening, and a couple of months for treating. So far at our 2 pilot sites, there were more than 1,000 people have been screened for hepatitis B and hepatitis C. More than 100 detected positive, and 30 hepatitis cases actually has started antiviral treatment. So having said everything that I want to share, that I strongly believe that primary care health workers can provide hepatitis care if they are trained and empowered. the community then can access the right hepatitis care at the right place and at the right time. So that's what all I have in mind to share. Thank you very much.
Very, very nicely put, Dr. Thuy. The right care at the right time at the right place is certainly what we aim to do with people-centered care. Coming now to Todd, someone who has worked in Vietnam for over a decade and seen plenty of projects start and end. I guess what I wanted to ask you was, in order to turn this good initial research and particularly this implementation research and training and capacity building into sustainable change, what's required, and what are some specific examples of where we've been able to do that in the Stitch project?
Thanks, Beth. Yeah, I think in any health systems project, having sustainable change is, one of the ultimate goal that we're looking for. And I think I'd like to share sort of some lessons learned in that area over my, 15 years working on health systems projects in Vietnam and other Southeast Asian countries. I think you'll recognize some of the themes I mentioned in the comments made by the previous panelists already, as well as in the words that you and David gave in your presentations. I'd say the first theme is about partnerships. So, having strong partnerships that are built on a foundation of mutual trust is really necessary to accomplish anything. And we heard some examples from Manu about how to, create those strong partnerships, karaoke and other things as well. But, I think the point is that it takes time, it takes resources, and takes commitment to build those partnerships. And I think a lot of people, of course, talk about partnerships, but you really need to think about, you have to take active steps to make those partnerships strong. And how do you build trust? Well, one of the ways is that you are responsive to the needs of your partners. So, within the best of your abilities, you try to respond to the needs that they have that you might be able to support. And whatever project or whatever research you're conducting is answering relevant questions to them at the local level. I think there's many examples from the Stitch project for that. I mean, in terms of building trust, our group has been working in Vietnam for 20 years now. So we've had plenty of time to build up relationships and trust. And in fact, the main partner from the Department of Health in the province that the Stitch project is working is someone that we worked with in a previous project many years ago when he was in a different position. And now we've come back to him, and we already have that existing trust. And I think it really helped to get the project off the ground in the early stages in Vietnam. I think the second lesson is about engaging and empowering stakeholders in the work. And by stakeholders, I mean everyone, of course, the policymakers, but as well as the practitioners, like the health providers, the health managers, and of course, the people with lived experience, as we've been talking about. And when we're talking about engaging in the work, we're talking about from the beginning, identifying the questions that needed, designing the research methodology, and implementing the research. So not just in sort of disseminating the results or reflecting on the results, but actively involved from the beginning. And there are many examples. I mean, the whole Stitch project is built on that foundation of a co-design approach. So I think it embodies that principle. The third lesson is about context. It's so important to understand the context that you're working. And by context, I mean like the social, cultural, economic, and in particular legal context when we're talking about policy change. So that's why in the project, the first step we did was like a policy review analysis to understand, what's the current state and what are the gaps in policies that the project could perhaps inform. And I think one of the things we learned was when we're talking about policies, there's kind of like sort of big health policies that you might want to influence with your project, but it's sort of very local level policies that need to change. And one example of that, is about specimen transfers. So in order to get PCR testing done at some facilities that didn't have that testing on site, specimens could be transferred to another facility, but that required new policies to be developed in order for health insurance to coverage, and in order for the mechanism to be set up. And so the project was able to accomplish that at the site level. And then the last lesson learned, I would say, is that it's important to build in mechanisms for quality improvement, for mechanisms for adapting, learning, and scaling up from the very beginning of the project. So any project you put into place is not going to be perfect. It's going to need to be continually improved upon, continual iteration. And, obviously, in this project, we're starting from one province in Vietnam, one region in Philippines, but the ultimate goal is to have the lessons learned from that to be scaled up. And that was a goal, a very conscious goal from the beginning, and built into the project design to have a scale up phase as well. So I think those are sort of 4 lessons that I've learned, and I think the Stitch Projects is embodying those lessons. Thank you.
Thank you, Todd. Such a wealth of knowledge from your time spent doing this work and building the relationships. I think now, just turning to our final panelist, Sinit, what Todd has described isn't the usual kind of project that we might see Gilead partner with academics and governments in, and partnerships and relationships in between the pharmaceutical sector and other stakeholders are sometimes challenging. Over to you. What brought about this partnership, and how does it differ from previous efforts that you've made as an organization?
Sure. Thank you so much, Beth. At Gilead, I lead our health systems engagement group, and I sit in a group referred to as Global Patient Solutions, which is responsible for 96 countries in Africa, South Asia, Southeast Asia, and Central Asia. And my role is really focused on public-private partnerships that are part of our kind of health system strengthening efforts and our broader access strategies in the region. So in industry, we're really good at partnering with academic institutions as part of drug discovery. And this is part of our core operations, and working in this way has really resulted in transformative treatments. But we know that those treatments do not reach all who can benefit. And we understand that there's a need to bring the same rigor and boldness that we bring to our science to the way that we innovate in service delivery. And Stitch is an example of how we try to bring that ambition forward within Gilead. So how do we kind of reach all who can benefit with different types of approaches? And David and Todd always say that decentralization does not equal people-centered. You have to build those pieces in. And what I want to focus on is talking about kind of operationally what is required from that, because of course, all of our esteemed colleagues on the panel have talked through the technical elements of what people-centered design looks like. And this is more geared towards those funders that are in the room, even though at Gilead, we don't consider ourselves funders, and the implementation science researchers that are developing and designing these programs. And it really comes down to time and resources. So when we talk about time, we've heard a lot about what it required to kind of start the preparation phase of this program. And, we followed a cohort of patients for 8 months, did several landscaping exercises to really understand what are the barriers and enablers. And if you think about it, and then moving into this co-design process, which was really well explained here, but to some is an ambiguous term. So when you talk about these things internally and talking about designing these programs, you're talking about it's a year before I can tell you exactly what it is that I'm going to do. And when I actually understand what the barriers are, I'm going to take another 6 months to co-design a process. And so that requires a nuanced discussion about bringing the person centricity to the table. And what does that actually require? changing that power paradigm from having a seat at the table for those with lived experience to lead the table. And so, this is part of what is required to be people-centered, is to bring some of those discussions to the table and understanding from a time and resourcing perspective what is required. And Joshua and Manu, you talked about this a lot in your discussion, the co-design workshops and how they progressed in terms of trust building and in terms of bringing those perspectives of those with lived experience to the table, and kind of that challenge and debate process. And those elements require time and resources again. So when we talk about the people-centered approaches, we need to design programs that give that time and allow for that process. And so for me, that this is the different way in which we're working at Gilead, and this also brings what the innovation is around this partnership. And then lastly, I want to talk about this trust element, of course, as the industry person sitting on the panel. When I asked Lisa and Todd and David, what has been the critical success factors of your program in Vietnam? Of course, we hear about time and about, the things that Manu said around trust building. And I have, of course, a career in public health and global health. But when I sit in my pharma hat and I answer that question, for me, it's really, doing what you say you're going to do. And that is the easiest way to build trust and bring in these other elements that others have spoken about on the panel. So, for me, I think these pieces are really the part of the partnership that is challenging and working differently at the perspective of Gilead when we think about health system strengthening and how we work to innovate in service delivery. So thank you for that.
Brilliant. Thank you so much, Sinit. I'm noting the time. I'm going to hand it back to David to wrap us up. But thank you to all of our panelists for bringing such great perspectives to this discussion.
Great. Thank you so much to Beth, and thank you to our panelists again for that rich discussion. So in our last minute together, just to run everyone through the key takeaways from this session, which is that people-centered care is feasible, it's value, it's ethical to involve people with lived experiences in all aspects of research and project design and delivery. Meaningful community engagement and co-design is time and resource intensive, as we have heard, but it's a necessary investment to support local ownership and problem solving. And for those of us in the Harvard ecosystem here, it's really necessary that we advocate to our donors and our funding sources that we do need this intense resource commitment in order to do this appropriately. Primary care is where people-centered care should occur for most health conditions because it's convenient, affordable, and equitable. Implementation research can influence system and policy changes at the national and the subnational levels, and that public-private partnerships with private sector and industry can really go beyond industry, and we should really focus also on service delivery and how to get those amazing breakthroughs in medications and devices to patients. Thank you, and I'll hand it back to the conveners of this grand rounds.
Great. Well, I'll just thank you for that tour de force. It was really fantastic. We really appreciated the format you brought and bringing all of your collaborators together. Really insightful. Thank you all so much. Appreciate it.
Thank you.
Thank you.
Thank you.
Thanks, everyone.